আর সময় পাবেন।
ভাই শুরু করেন।
আমরা এখন শুরু করতে পারি।
Assalamu alaikum. Welcome all of you. Today is our webinar on today our topics is hypertrophic cardiomyopathy and restrictive cardiomyopathy. We have 6 speakers in 6 individual parts. First of all, we will start about the HCM. Regarding the HCM, the speakers are Dr.S.M.Rahiduzzaman. She will discuss about the pathophysiology, definition, and clinical features. Then echo diagnosis will be talked about by Dr. Khan, and treatment and diagnosis will be talked or discussed by the Dr. Habibur Rahman, Associate Professor. And regarding the restrictive cardiomyopathy, the definition, pathophysiology, and clinical features will be talked by Shamimur Rahman. Echo diagnosis will be elaborated by Professor Tuhin Haq, and diagnosis and treatment will be discussed by Dr. Abdul Qayyum Khan. And today in this webinar, the panel of experts are Dr. Monwarul Islam. He is Associate Professor of NICBD, very brilliant and dynamic academician. And another panel of experts is Tanjima Parveen. She is Associate Professor of Bangabandhu Sheikh Mujib Medical University. So before going to start the webinar, I will request our head of the department and chief cardiologist, Professor Fazilatul Malik Madam, to say few words regarding the webinar in front of the audience.
Thank you, Dr. Rahiduzzaman. And it is indeed a great pleasure and honor for me to be here as usual. And I hope to learn a lot, which we always do with all sessions. And I would like to thank our panel of experts because we hope to learn a lot from them about what would be important for the students during the examination. So without further ado, I think we can start our lectures and deliberations for this evening because we've got 6 speakers. And I would request all the speakers to keep in time. It's around 12 minutes. At maximum, I think they can go for 15 minutes because it's 6 speakers. So everyone has to be very brief and very precise. So thank you for giving me this opportunity. Thank you.
Okay, thank you, Madam, for your brief and elaborate, nice speaking. First, I will invite the Dr. Rahiduzzaman to talk about or discuss about the definition, pathophysiology, and clinical features of hypertrophic cardiomyopathy. Dr. Rahiduzzaman.
Thank you, sir. Respected moderator, expert panelist, and all participants, Assalamu alaikum. I will be presenting hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is defined as left ventricular hypertrophy in the absence of abnormal loading conditions such as severe hypertension or valve disease. It was described by Brock in 1958 and Thierry in 1959. Since then, it was described under headings of different headings, but right now, hypertrophic cardiomyopathy is the most preferred and generally accepted term with or without outflow obstruction. It is found 1 in 500 cases, but recent estimates suggest it's closer to 1 in 200, equal frequency seen in men and women. It's been reported in many countries, more than 15 countries from all over the globe. Overall mortality rate is less than 1% per year. 40 to 60% cases, HCM results from sarcomeric protein gene mutation that follows autosomal dominant pattern of inheritance. 5 to 10% cases, there is genetic or familial metabolic and storage disorder. For the rest of the 25 to 30% cases, cause remain unknown. More than 1,400 mutations seen in 11 or more genes encoding proteins of contractile myofilament component of the cardiac sarcomere, of them beta myosin heavy chain and cardiac myosin binding protein C genes are most important. Also, troponins are involved, which are more harmful, associated with 50% mortality before the age of 40 years. Classical histopathologic appearance are myocyte hypertrophy, myocardial fiber disarray, interstitial and perivascular fibrosis, intimal and medial hypertrophy in intramural arteries. All these changes lead to disorganized cellular architecture, which leads to asymmetric septal hypertrophy. Left ventricular wall hypertrophy results in reduction of ventricular cavity. There is also enlargement of the left atrium, and coronary arteries may follow an intramural course which can be compressed during ventricular systole. Mitral valve apparatus show a number of abnormalities with elongation of the chordae tendineae, anterior displacement of the hypertrophic papillary muscles, abnormal attachment of the mitral valve chordae into the septum, insertion of the papillary muscle head directly into the mitral leaflets. There are 4 complex interrelated factors involved in the pathophysiology of HCM, namely left ventricular hypertrophy, left ventricular outflow obstruction, left ventricular diastolic dysfunction, myocardial ischemia, and mitral regurgitation. This obstruction is dynamic and is caused by contact between the septum and mitral valve leaflets during ventricular systole in 1/3 of patient at rest and in further 1/3 during exercise. This dynamic obstruction increases when there is decrease in preload and afterload and increase in contractility, and decrease in exactly opposite situation. This is due to systolic anterior motion of the mitral valve occurs secondary to a combination of the Venturi effects result from projection of hypertrophied basal ventricular septum during systole and drag forces that results from flow against of abnormally positioned mitral valve that pushes the anterior mitral leaflet towards LVOT. As mitral leaflets are anteriorly positioned and redundant, thus drag forces predominant. There are certain factors like septal hypertrophy, anterior displacement of the mitral papillary muscles, and elongation of the mitral leaflets and chordae are the factors that predisposes the formation of systolic anterior motion of the mitral valve. Elevated intraventricular pressure, prolongation of ventricular relaxation, increased myocardial wall stress, increased oxygen demand, decrease in forward cardiac output are the physiological consequences of LVOT obstruction. Diastolic dysfunction develops from high systolic contraction load caused by LVOT obstruction. There is non-uniformity of ventricular contraction and relaxation. Delayed myosin actin inactivation caused by abnormal intracellular calcium reuptake. As the disease progresses, both diastolic and systolic function progressively deteriorates. That leads to mild to moderate LV dilation, decreased LV wall thickness, a reduction in LV ejection fraction. In some patients, moderate to severe pulmonary hypertension develops in these advanced stages. There is increase in demand due to ventricular hypertrophy, increased LV systolic pressure, increased LV filling pressure. Also, there is reduced supply of oxygen due to abnormally small and partially obliterated intramural coronary arteries. Besides, there is myocardial energy metabolism is compromised. All this leads to a supply-demand mismatch that leads to myocardial ischemia. Mitral regurgitation caused by distortion of the mitral valve apparatus from systolic anterior motion secondary to LVOT obstruction. Changes in ventricular load and contractility affect the degree of mitral regurgitation. The jet is directed laterally and posteriorly, predominates during mid and late systole, and is proportional to the severity of LVOT obstruction. Clinical presentation varies widely from asymptomatic to when symptomatic, that can be devastating. Most common symptom is dyspnea due to heart failure. In advanced heart failure, there may be orthopnea, paroxysmal nocturnal dyspnea. Symptoms of heart failure can occur at any ages. About 2 to 3% patient can develop advanced, that is NYHA 3 and 4 heart failure, which is more commonly seen in patient with LVOT obstruction than in non-obstructive variety. Angina is due to myocardial ischemia and frequently unrelated to epicardial coronary artery disease, syncope and presyncope resulting from LVOT obstruction that worsens during exertional activities, resulting in decreased cardiac output. activation of LV baroreceptors resulting in reflex vasodilation and can be secondary to atrial and ventricular arrhythmia. Palpitations are due to arrhythmia. There are various types of arrhythmia seen in HCM. Among them, atrial fibrillation, ventricular tachycardia, ventricular fibrillation are more common. Atrial fibrillation seen in 25 to 30% cases. This figure shows the complex pathogenesis of atrial fibrillation that can lead to thromboembolic manifestation, heart failure, LV systolic dysfunction, and sudden cardiac death. HCM is the most common cause of sudden cardiac death among young individuals, including athletes. It can be the first manifestation, may occur at a wide range of ages, and mainly due to ventricular fibrillation, either de novo or atrial fibrillation degenerates into ventricular fibrillation. There are certain factors that increases the likelihood of having sudden cardiac death. These are sustained ventricular tachycardia, severe LV hypertrophy, abnormal exercise blood pressure response, unexplained syncope, family history of sudden death. This figure shows that most of the death occurs during rest, but death during exercise is not uncommon, and death can occur at any age. Classic physical findings are present in patients who have LVOT obstruction. Those who do not have obstruction may have findings of LVOT on physical examination. The classic carotid pulsation is brisk with spike and dome pattern. There is rapid rise, then a mid-systolic drop, and followed by a secondary wave. Jugular venous pulse may be normal, but a wave can be prominent if there is decrease in ventricular compliance. Apex is formed by hypertrophic left ventricle, which is localized and often sustained. There may be palpable third and fourth heart sound, a triple ripple with a third component occurring near the end of systole if outflow obstruction is present. A systolic trill at apex from severe MR or at the lower left sternal border from outflow tract obstruction. First heart sound usually normal, but sometimes can be loud. There is physiological splitting of the second heart sound, but sometimes there can be a paradoxical split as a result of concomitant LVVV or severe LVOT obstruction. Third and fourth heart sound can also be audible. The classic murmur is a crescendo-decrescendo murmur, based hard at the apex and left lower sternal border. It is medium pitched, ends before the second heart sound, can radiate to the base and apex, seldom radiates to the carotid arteries. Intensity of this murmur increases with decreased in preload. Likewise, intensity decreases when preload is increased, which is exactly opposite phenomenon seen in fixed LVOT obstruction such as aortic stenosis, when increased preload increases murmur and decreased preload decreases the intensity of the murmur of aortic stenosis. Besides, there is a holosystolic murmur of mitral regurgitation can be audible at apical area. Thank you all for patient hearing.
Thank you, Ismail. Thank you, Ismail, for your confident speaking. Now we will discuss the questions and answers at the end of our total discussion. Now, at this moment, I will invite Dr. Rahiduzzaman. He will talk about the diagnosis and treatment of the hypertrophic cardiomyopathy. But in between this, the echocardiographic part will be talked by Dr. Abdul Majid Khan. So, Dr. Rahiduzzaman, please, diagnosis and treatment of hypertrophic cardiomyopathy.
Thank you, sir. Am I visible and audible?
Yes.
So my topic is hypertrophic obstructive cardiomyopathy. The part is diagnosis and management. So for diagnosis of hypertrophic cardiomyopathy, mostly dependent on clinical evaluation, laboratory investigation, and after exclusion of mimics of HM, that means differential diagnosis. So as mentioned by Dr. Ismail, I would just like to mention quickly. So carotid pulsation is important point to node down, and also apical pulsation and the heart sounds. Of course, the apex and systolic murmur of MR to be differentiated, and jugular venous pulsation is very important clinically, needs to be meticulously looked after. As she already mentioned, that it should be differentiated from aortic stenosis by certain dynamic auscultation maneuvers. So some signs and symptoms also suggesting some diagnostic clues. If there is learning difficulties or mental retardation, sensorineural deafness, visual impairment, which can be confused with hypertrophic cardiomyopathy, particularly in children, by mitochondrial disease and some other diseases like Fabry disease. If there is gait disturbance along with features of hypertrophic cardiomyopathy, may be confused with Friedreich's ataxia. So as muscle weakness and palpebral ptosis should be looked clinically for. For diagnosis regarding the lab investigation, ECG is in the central part. Sometimes patients coming with ECGs like STT changes, T inversion, and general physicians confused with acute coronary syndrome. They urgently refer patient to emergencies, cardiac emergencies to get admitted, but patient remains asymptomatic. So what are the ECG changes? These are STT changes, mostly inversion, ST depression, along with left ventricular hypertrophy. There may be giant T-wave inversion, particularly in apical variety of hypertrophic cardiomyopathy. There may be pseudo-infarction pattern, that means Q waves in inferior or other lateral leads. There may be left axis deviation. There may be evidence of left atrial enlargement, and there may be pre-excitation. In some cases, about 6% of cases, ECG may be normal, or there may be non-specific changes. Some ECG findings suggesting specific diagnosis. If there is pre-excitation, it indicates there might be storage disorder. If short PR interval with pre-excitation, maybe storage disorder. If there is AV block, mitochondrial disease, or amyloidosis. And if there is severe LV hypertrophy, it also indicates storage disorder. So another investigation is X-ray chest behavior, may be normal, or there may be mild cardiomegaly with pulmonary congestion. And there may be evidence of left atrial enlargement. And in the obstructive form, eccentric aortic enlargement may be found. And LV type of cardiomegaly, particularly in the end stage of the disease. Another important investigation is Holter monitoring. It is also useful to detect paroxysmal atrial fibrillation or non-sustained VT, and should be repeated every 1 to 2 years. Frequent and prolonged episodes of non-sustained VT are a marker of sudden cardiac death. That patients should be identified properly to prevent sudden cardiac death. In some cases, exercise tolerance test is needed for the demonstration of exercise-induced obstruction, assessment of functional capacity and risk stratification, and for the differential diagnosis of unexplained hypertrophy. Up to 25% of patients with HCM have an abnormal blood pressure response during upright exercise. either due to abnormal vasodilatation in non-exercising muscles or impaired cardiac output and a reduction in peak oxygen consumption compared with healthy controls. However, respiratory gas profiles indicative of severe and premature lactic acidemia can be only clue to the diagnosis of mitochondrial myopathy. So, recent ACC AHA guideline also recommends for exercise tolerance test. In some cases, magnetic resonance imaging, that is CMR, is mandatory. When diagnosis is when uncertain that LVH not recognized on echocardiogram, it is mandatory to do to exclude phenocopy, that is differentiation from non-compaction cardiomyopathy, and also differentiation from hypertensive heart disease or athlete's heart disease. When diagnosis is confirmed, the markers of increased sudden cardiac death identification, that is extensive gadolinium enhancement, extensive LVH, and if there is apical aneurysm. So it should be done. For the management purpose, septal morphology to see properly to septal ablation and obstruction localization, also to look at the mitral valve anatomy properly. So regarding the management, it includes core counseling, familial screening, assessment of risk of sudden cardiac death, and treatment of symptoms. What is core counseling? Patients should understand the prevalence of hypertrophic cardiomyopathy as well as the fact that the majority of patients live near normal lifespan without advanced therapies, but that for some patients, significant symptoms and arrhythmias may occur. Manage other diseases according to the relevant guidelines and participate in regular low-intensity physical activity as a part of healthy lifestyle. Maintain hydration, should not be dehydrated, and refrain from competitive athletics. And also family screening is very important. And it should be commenced at the pubescence and participation in the intense competitive athletics or symptoms, whichever is earliest. Either imaging or genetic testing can be used. If the patient chooses not to pursue genetic testing or no clear HCM associated mutation is identified, then screening with ECG and echocardiography is recommended. Every 5 years for adult relatives not participating in athletics, annually for athletes and adolescents. If a definitive HCM associated mutation is identified, genetic screening becomes the preferred methodology. Another important issue is sudden cardiac death. These patients should be prior and needs to be identified prior. So the risk factors of sudden cardiac death are personal history of cardiac death or sustained ventricular arrhythmia, family history of cardiac death in first degree relatives, maximum left ventricular wall thickness, recent unexplained syncope, non-sustained ventricular tachycardia on a 24-hour ambulatory ECG, and hypotensive or flat blood pressure response during exercise. These are the markers which indicate sudden cardiac death may happen. So it should be identified as per recommendation of AHA and SCC guideline. To whom the personal history of cardiac arrest or sustained ventricular arrhythmia, personal history of syncope or suspected by clinical history of arrhythmia, family history in close relative, as already mentioned, here categorically mentioned by the guideline. I'd like to skip this. So to prevent this sudden cardiac death, ICD implantation is an option for whom in patients with hypertrophic cardiomyopathy, application of individual clinical judgment is recommended when assessing the prognostic strain, conventional risk markers within the clinical profile of the individual patient, as well as to balanced discussion of evidence, benefits, estimated risk, to engage the fully informed patient's active participation in ICD decision making. For patients with hypertrophic cardiomyopathy and previous documented cardiac arrest or sustained VT, ICD placement is recommended. So patients should be selected accordingly by the guideline. Some clinical features identifies the risk of sudden cardiac death, as already mentioned. So invasive treatment of symptomatic patients with obstructive hypertrophic cardiomyopathy, HOCM, general eligibility for criteria for septal reduction therapy, either surgically or by percutaneous procedures. That is, clinical criteria includes severe dyspnea or chest pain. Other exertional symptoms, either syncope or near syncope, when attributable to LVOT obstruction that interferes with everyday activity or quality of life despite optimal medical therapy. Hemodynamic criteria, that is LVOT gradient at rest or with physiological provocation with approximate peak gradient of equal to or more than 50 millimeter of mercury associated with septal hypertrophy and SAM of mitral valve. Anatomic, that is targeted anterior septal thickness sufficient to perform the procedure safely, effectively in judgment of individual operator. Regarding the dual chamber pacing, once it was recommended strongly, but nowadays by randomized trials, it's found that it has placebo effect. There is no definite role. Regarding management of symptoms, medical treatment should be employed first. And for medical management, beta blocker should be applied in the first line therapy. And if beta blocker is contraindicated, then non-dihydropyridine calcium channel blocker. If there is hypotension, then disopyramide either should be applied or should be added to beta blocker or to calcium channel blocker. Success of medical therapy is based on symptomatic response, regardless of residual gradient. If symptoms persist and interfere with quality of life despite adjusting medication, then consider for invasive therapy. So if there is high surgical risk, then percutaneous option, that is alcohol ablation, or if there is no surgical high risk, then surgical myectomy is indicated. So in summary, invasive treatment includes ICD implantation, pacemaker, alcohol septal ablation, and surgical myectomy. So how alcohol septal ablation is done? It is done by doing angiography and putting a balloon in the first septal perforator, which is shorter balloon, a bit larger than the septal artery. First, contrast angiography is done to mark the area to be ablated, then 1 to 3 ml of 100% alcohol is infused in controlled fashion. It is important that balloon be inflated, and that contrast injection also show that there is no extra basation of dye into the LED. If there is contrast and enhancement in other regions, particularly the collateral circulation switches the dye to other regions, then it should not be done. What happens after alcohol ablation? LVOT gradient shows a triphasic response following alcohol ablation. That is stage 1. It is stunning phase. There is immediate decrease in gradient following alcohol ablation. It is stunning of the septum. And stage 2, that is edema phase. There might be some increase in LVOT obstruction due to peri-infarction edema. This is the reason for recurrence of gradient during discharge time and lasts for 5 to 10 days after the procedure. And the third stage, that is scar phase, LVOT obstruction gradually decreases as scar forms over weeks or months, and septum becomes thinner gradually. This stage lasts for 3 to 12 months after ablation. Thus, accurate success of ablation can only be determined after 3 months. Another important test is broken bow response. That is, by inducing BPC, the LV pressure increases, aortic pressure decreases, and gradient between LV and aorta increases. That means post-PVC response, it is called broken bow response. So how surgical myectomy is done? This is an open heart procedure requiring heart-lung bypass machine to raise the heart and performed by resection of small portion of the septum from proximal septum through the aorta. So the comparison between septal reduction therapies and percutaneous and surgical, that is, in surgical, it is chosen patients are younger, healthy.
I think
Any network problem?
yeah, there is a problem.
Am I audible now?
Now it is audible. Yes.
Okay, so
No, you are not audible.
Yes, audible. I can hear him.
okay, just
Yes, I
yes.
think you can short it. Huh?
Okay, just
You go to the end.
okay. So regarding the lifestyle consideration for patients with hypertrophic cardiomyopathy, what about sports and activity? For most patients with HCM, mild to moderate intensity of recreational activities can be allowed for cardiorespiratory fitness, physical functioning, and quality of their life. And pregnancy is well tolerated. Vaginal delivery is preferred, and comorbidities should be treated. Hypertension should be addressed, and other diseases should be treated. So, what are the emitters of hypertrophic cardiomyopathy? Sometimes confused with hypertension when not well controlled and having widespread LVH, and chronic renal failure and other storage diseases, particularly amyloidosis, and athletic adaptation, that is athlete's heart. So in conclusion, clinical evaluation of hypertrophic cardiomyopathy has no alternative. Risk stratification of sudden priority in case of hypertrophic obstructive cardiomyopathy. Medical management needs special attention to certain modalities of drugs. Invasive approach needs to be tailored according to the patient's condition, and near normal life leading is possible with taking appropriate measures in most of the patients. So thank you for patient hearing.
Thank you, Dr. Habibur Rahman, for your elaborate discussion. I will request Dr. M.A. Mujid Khan for echocardiographic diagnosis of the hypertrophic cardiomyopathy. Very important part. He's the one of the topmost ranked echocardiographists in Bangladesh. Okay, thank you, Dr. Abdul Mujid Khan. Go on with your discussion.
Thank you very much, my colleague Dr. Rahiduzzaman, present audiences. Okay, Dr. Habib has taken almost half an hour. I'll finish, inshallah, in 15 minutes. Can you hear me, please?
Yes, yes, we can hear you.
Okay.
Right?
My part is the echocardiographic assessment
Yes.
of hypertrophic cardiomyopathy. So, Dr. Ismail has described the overall definition of hypertrophic cardiomyopathy. The echo diagnosis of hypertrophic cardiomyopathy records the left ventricular hypertrophy should be equal to or more than 15 millimeter, and the asymmetric variety should be more and more than the symmetric variety. In the absence of another cardiovascular or systemic disease associated with LVH or myocardial valve thickness. This echo definition. And 3 points should be noted. Frequently, we think that these are mandatory for the diagnosis of hypertrophic cardiomyopathy. The asymmetric septal hypertrophy, systolic anterior motion of the mitral valve and SAM, and the dynamic elevator obstruction. These are not essential parts of for definition of hypertrophic cardiomyopathy. Like any other disease, for assessment of hypertrophic cardiomyopathy, a systemic approach should be followed. First, left ventricular hypertrophy should be confirmed. Then elevator obstruction should be assessed. Then the systolic anterior motion of the mitral valve should be assessed. And then the LV systolic and diastolic function and the left atrial size. All will give us the necessary information. First, the confirmation of the left ventricular hypertrophy. Left ventricular hypertrophy may be present in any segment of the left ventricle, most in the basal segment, may involve the isolated lateral or posterior septum and the elevators. And the criteria for the diagnosis of left ventricular hypertrophy are unexplained hypertrophy equal to more than 15 millimeter in any myocardial segment, or septal posterior wall thickness ratio more than 1.3 in normotensive patients, or septal posterior wall thickness ratio more than 1.5 in hypertensive patients. Here you can see this is the traditional classification of hypertrophic cardiomyopathy. Still, we are practicing this. This is the asymmetric septal variety. In the old studies, present in 65% of cases. Concentric variety is present in 35% of cases, and the apical variety is present in about 10% cases, almost mostly present in the Japanese population. And here you can see the obstructive variety of the asymmetric septal variety. Recently, the left ventricular morphology is redefined and geometry is redefined according to the shapes of the septum in the LV. The septum in the hypertrophic cardiomyopathy, septum may be sigmoid shaped, mostly involving the basal segment, and is seen on the apical long axis. So, in sigmoid shaped, the basal segment is most hypertrophic, then the mid and distal segments. The reverse septum, it is convex shaped, protruding into the LV, and in the neutral septum, it is uniform throughout the whole length of the septum. And the next variety is the apical hypertrophy. There is the apex is disproportionately hypertrophy. And the percentage you can see mostly sigmoid variety is present in 47% cases. Next common is the reverse septum, 35% cases, and neutral septum 32%, apical variant 10%. Here you can see the apical long axis view images, the sigmoid septum, reverse septum, the neutral septum is the apical hypertrophy. These images are from our eco lab. First analysis view of the sigmoid shaped septum in asymmetric septal variety. Short distance view of septum in asymmetric septal variety. This is also sigmoid shaped septum in asymmetric septal variety, also showing the obstruction in the LV. These are MOD image of the asymmetric septal variety. Anterior septum is about 18 millimeter, and the posterior wall is about 13 millimeter. These I am also showing just for the students. This is the apical variety of hypertrophic cardiomyopathy. Apex is disproportionately hypertrophic. Apical long axis view showing the disproportionate hypertrophy of the apex in apical hypertrophic cardiomyopathy. This is a variant of apical septal hypertrophy complicated by the formation of apical pouch or septum. The apical presence of the pouch or aneurysm is complicated by progressive heart failure or death in 18% of cases, sudden cardiac death or revived cardiac arrest in 14%, appropriate ICD discharge in 11%, and non-fatal embolic stroke 7%. Because in the aneurysm, this maybe thrombus may be formed. Now the eco-differential diagnosis of right ventricular hypertrophy in HCM, the cardiovascular and systemic disease. The acquired variety, hypertension is the most common, next after stenosis. Athletes are right ventricular hypertrophy. Frequently, right ventricular hypertrophy due to RVO obstruction or formal stenosis is reported as hypertrophic obstructive cardiomyopathy. Frequently, we are getting the echoes from outside. So we should be cautious about this. And the inferior MI with preceding right ventricular hypertrophy. Due to MI, the inferior posterior wall becomes thin and the compensated hypertrophy of the septum, like the asymmetric septal variety. The congenital differential diagnosis is subaortic stenosis. Then we will discuss subaortic membrane or band or tubular band and the LV non-compaction. Systemic disease, Dr. Habib already described the causes, so I am not going into details. This is an echo image of LV non-compaction, which is confused with the apical hypertrophy. You can see the trabeculated mid-distal lateral wall and the distal ibis. This sometimes confused with the apical variety of hypertrophic cardiomyopathy. Actually, this is non-compaction. Alveolar obstruction. At least in 25% of cases, more than 30 millimeter gradient is found. So dynamic obstruction is present in this 70% of cases. And the pathology is already described by Smart. I'm not going into details. This is the echo image of the systolic anterior motion in the M-mode variety. Frequently given in exam, you can see the convex shape of the systolic anterior motion of the mitral valve. Normally, the two leaflets opposes together like a straight line. Mechanism of SAM already described by Smart, just I'm repeating. Previously, Venturi effect, there is the suction from the LVOT tunnel. This was considered to be the major determining factor, but nowadays, flow drag factor is presumed to play the dominant role. This is the hydrodynamic pushing force of flow behind the mitral leaflets plays the dominant role. And then the Venturi effect. And the obstruction, once set up, it begets more obstruction. Abnormalities contributing to the systolic anterior motion, already described by Smart. I'm not going into details. SAM and LVOT obstruction, not synonymous and not present in the same proportion. SAM may be present without LVOT obstruction. 30 to 60% cases SAM is present, or LVOT obstruction present in 25 to 50% of cases. Hemodynamic consequences, ejection time is prolonged and reduction in stroke volume, and corporation failure resulting in the mitral regurgitation. The aortic valve, there is mid-systolic notch, and drag forces, already I told. The septal hypertrophy and crosses on the LVOT adding into the gradient. Frequently asked in the exam, what are the other causes of systolic anterior motion of the mitral? Basal septal hypertrophy without HCM. Frequently we see in the elderly patient cause severe degree of LVOT obstruction. Anomalous pulmonary muscle insertion may also cause, after aortic valve replacement with right ventricular hypertrophy and hyperdynamic ejection fraction, may may produce systolic anterior motion of mitral valve. Apical ballooning syndrome, the Taylor-Stubbe syndrome, may also cause systolic anterior motion. After mitral valve repair, there may be systolic anterior motion of the mitral valve. One case I referred from Bangladesh to Ahmedabad for mitral valve repair. There, they repaired, after repair, see the severe LVOT obstruction. So in the second operation, instead of repair, they replace the valve. Any positive anastomotic drug due to hypercontractility may cause systolic anterior motion of the mitral valve. Apical myocardial infarction with hyperdynamic function of basal myocardial segment. Apical myocardial infarction, the mid-distal IVS becomes thin and the basal segment becomes thick. So this basal thick segment may produce systolic anterior motion of the mitral valve. Massive mitral annular calcification may also produce systolic anterior motion of the mitral valve. And hypovolemia due to any cause may, if a small LV cavity with hypovolemia is present, may also produce systolic anterior motion of the mitral valve. This is the obstructive variety of sigmoid shaped septum in hypertrophic obstructive cardiomyopathy. This is a professional long-axis view of sigmoid shaped septum in obstructive variety of hypertrophic cardiomyopathy. This is the MR. You can see the LVOT obstruction. LVOT obstruction produces eccentric rate of mitral ejection. Obstructive variety of hypertrophic cardiomyopathy. Now they are Doppler signal, frequently confused part of the LVOT gradient. Frequently we are getting the echoes from outside, gradient 200 millimeter mercury. There is, thus they give the gradient of the mitral regurgitation. You can see the shape of the Doppler signal of mitral regurgitation is elliptical, and that of alveolar gradient is dagger shaped. So sometimes it is difficult to get the alveolar gradient. By practice you can get, and if the direction of the flow permits. So we should repeatedly try to get the actual alveolar gradient, because depending on our report, the intervention cardiologist, they take the decision, or the surgeon take the decision of septal ablation or myectomy. If alveolar gradient could not be determined directly by echo, indirectly by MR gradient, you can determine the alveolar gradient. Peak alveolar gradient equal to MR gradient plus left atrial pressure minus systolic blood pressure. Here see the MR velocity is 6.9 square meter, so 4 velocity square equal to 190 plus assumed left atrial pressure is 15. 190 plus 15 equal to 205, the LV pressure. And systolic pressure is taken to be 100, LV pressure is 100. So 205 minus 100 is the alveolar gradient, 105. So if alveolar gradient directly cannot be measured indirectly from MR gradient, we can measure. Now the dynamic nature of the alveolar obstruction is safe. A systematic approach to propagation should be used. Dr. Habib will describe a bit, just I'm repeating. If the raise gradient is more than 50 millimeter mercury, it is definite that obstructive physiology is present. If it is not present, Valsalva maneuver should be exercised. If it becomes more than 50, obstructive physiology is present. After Valsalva, if it is less than 50, amyl should be given. If it becomes more than 50, obstructive physiology is present. If still after amyl nitrate it is less than 50 millimeter mercury, stress gradient, especially in symptomatic patients, exercise stress echo should be practiced, because pharmacology, dobutamine stress echo is usually contraindicated. If exercise stress echo shows gradient more than 50, obstructive physiology is present. And after all, if it is less than 50, after exercise echo, finally cardiac cath should be done. In the cardiac cath, if it is more than 50, it is definite that the obstructive physiology is present. Intercapillary obstruction unrelated to SAM. Sometimes we confuse the alveolar obstruction with the interventricular obstruction. So if the interventionist do alcohol ablation of the septal perforator, or the surgeon do myectomy, after the procedure, the intercapillary gradient remains the same. Frequently we see. Other echo features are the same: mid-systolic closure of the aortic valve, coarse fluttering of the aortic valve, and the fibrotic changes at the level of the leaflet septal contact. They are not shown in the 2D image. Mitral valve in HCM is already described by Smith. I am not repeating. Mitral regurgitation, usually the jet is directed posterolaterally, and if the direction of the jet is central or anteriorly, so we should consider other pathology, an intrinsic mitral valve abnormality. And if the transthoracic echo doesn't reveal, we should do transesophageal echo to determine any interventricular pathology. It is very important for the interventionist and the cardiac surgeon also. Now the assessment of systolic function. Ejection fraction is usually preserved with a significant impairment of longitudinal contractile function. EF is preserved, but despite significant impairment of longitudinal contractile function, evidenced by decreased MAPC, systolic velocity in tissue Doppler, systolic mitral annular velocity, strain and strain depth. In strain imaging identifies the regional heterogeneity even in the patient with the normal ejection fraction. In the late phase, there is myocardial fibrosis, which leads to progressive impairment of systolic function, and the end stage is same, also called the bound out hypertrophic cardiomyopathy. Duration of systolic function leads to increased mortality, 11% per year, and silent cardiology. Now the diastolic dysfunction. In hypertrophic cardiomyopathy, there will be varying degree of diastolic dysfunction. Here you can see the type 1 diastolic dysfunction. In the MB info view, A wave more than E wave. But one thing always should be remembered that despite normal filling pressure, E prime velocity may be decreased in the hypertrophic cardiomyopathy. Here you can see the E prime velocity is only 3 centimeters per second. This is the type 1 diastolic dysfunction, mildly elevated filling pressure. This image is from our echo lab. This is the indeterminate variety of diastolic dysfunction. Here you can see the E velocity is 3 centimeters per second. Septal E prime 3 centimeters per second. Lateral E prime 4 centimeters per second. E by E prime 17, almost 18. But left atrial volume index is less than 40. So two criteria is met. That's why it is not type 1, even not type 3. So it is indeterminate variety. This is the irreversible restrictive variety, severely elevated filling pressure. You can see the restrictive pattern in the MB info pattern. And tissue Doppler velocity E by E prime is 40. E prime velocity is 0.03. LA volume is also very important. Left atrial volume index more than 34 ml per square meter has been shown to be predictive of a greater degree of left ventricular hypertrophy, severity of diastolic dysfunction, and adverse cardiovascular outcomes. Here you can see the decreased longitudinal strain with basal to mid apical gradient. Here you can see in the asymmetric septal variety, the global longitudinal strain has very much decreased in the endoseptal and septal lesion. You can see in the endoseptal lesion is -4, -5, -5. The septal lesion -12, -8, -9. In ferroseptal lesion -15. Almost all the segments. This is the contrast echo of apical variety of hypertrophic cardiomyopathy. These yellow segments show the cavity, and these are the walls. So the longitudinal strain of this apical hypertrophic cardiomyopathy, you can see in the center, they very much decrease global longitudinal strain, -1, -2, like this. Now in one study to differentiate between hypertensive LVS and HCM, the optimum cutoff value of the strain in the 4-chamber or 2-chamber view is at -10.6. The sensitivity, specificity, and predictive accuracy of this study was 8500 and 91%. 3D echocardiography shows insights into the mechanics of systolic anterior motion and deformational geometry of the alveoli, important for the interventionist and the surgeons for septal ablation and surgical myectomy. Now the transphysiologic echography, when it is needed. If the transthoracic wound is poor, alveolar obstruction mechanism is not clear, because the interventionist should be confirm the presence of any interventricular gradient due to the presence of interventricular abnormalities. This is a matter of abnormalities. Perioperative transphysiology guide the surgery and if detect any complications like VSD or actually aortic regurgitation. And when severe MR caused by intensive abnormalities is suspected. These are the indications for transphysiology. Contrast echo already I told, it can help when you severe the location and release the extent of septal infarction. So have you already told? Because if by contrast injection we can map the area then we can inject the perforator. These are the, already told by Dr. Habib, just repeating the alarming findings in echo maximum wall thickness more than 30, Elbow gradient more than 30, EF less than 50, all cause mortality left atrial diameter more than 48 millimeter, LA volume 27 millimeter, 27 ml per square meter as baseline, and the presence of interventricular dyssynchrony. All of these predicts unfavorable outcome. Now, these are for repetition. The role of echography in the management of hypertrophic cardiomyopathy. Already just I described the 1/3 of alveolar obstruction is present in 1/3 of patient, 1/3 obstructive, 1/3 level obstructive. Very significant gradient present after provocation. Gradient equal to or more than 50 millimeter mercury is considered of hemodynamic importance, and maximum or alcohol supply ablation is indicated. This is a new parameter, global functional index. Is GFI equal to E by E prime divided by S prime. There is a systolic velocity intercoupler of the medial metal annulus. If GFI more than 1.5, it supports the diagnosis of hypertrophic cardiomyopathy, then the hypertensive right ventricular hypertrophy. Now, how to differentiate between the athletes and hypertrophic cardiomyopathy? In Western country, athletes are routinely coming to for screening. In our country, they are less frequently coming. In the same, the unusual pattern of left ventricular hypertrophy, athlete usually uniform. In the same LV cavity, less than 45 millimeter usually, athlete more than 55 millimeter. Enlargement is usually not present in the athlete. Abnormal LV filling is usually present in SCM. Provocable LVOD gradient is not present in athlete's heart. Decreased thickness with deconditioning usually present in the athlete, not present in the hypertrophic cardiomyopathy. Dyssynchrony is present in the SCM, not in the athlete. Strain imaging definitely positive findings in SCM. And systolic material velocity less than 9 meters per second is definitely for SCM, not in athletes. Now, another term is the hypertensive SCM of the leg. Frequently in the elderly patients, we found the basal septal hypertrophy. We confused whether to describe it is a SCM or just basal septal hypertrophy. Sometimes we write SCM, sometimes basal septal hypertrophy. If we write hypertrophic cardiomyopathy, usually the thickness is less than 22 millimeter, small LV cavity size, hypertension is usually present, and ventricular morphology is greatly distorted with reduced outflow tract. Sigmoid septum is present and produces severe LV obstruction and the presence of SAM. This is known as granular SAM. This is present in the elderly patient. So I've come to the end of my lecture. The take-home message is comprehensive echocardiography is indispensable for the diagnosis and hemodynamic assessment of hypertrophic cardiomyopathy. Echocardiography plays an important role in the clinical risk stratification and also the interventional management of the patient with hypertrophic cardiomyopathy. 2D strain is a simple, rapid, and reproducible method to early detection of abnormalities in patients with hypertrophic cardiomyopathy. So, thank you very much for patient hearing. So I'm stopping my.
Thank you. Thank you, Dr. Abdul Majid Khan, for the double discussion. Now, for the time shortage, we'll complete the restrictive cardiomyopathy, then we'll go for the question and answer discussion. Now, regarding the chapter of the restrictive cardiomyopathy, the definition, pathophysiology, and clinical features will be discussed by Rahman, and echocardiographic diagnosis will be discussed by Professor Tuin Haq, and diagnosis and treatment will be talked by Dr. Abdul Karim. Now, this time, I will invite the Dr. Shamimur Rahman to talk about the definition, pathophysiology, and clinical features of restrictive cardiomyopathy. Dr. Shamimur Rahman, please start.
Thank you, sir.
we are short of time.
Assalamu alaikum. Respected teachers, dear colleagues, learned audience, Assalamu alaikum. Today, my topics restrictive cardiomyopathy. We see two pictures, one picture of heart, one is normal, another is restrictive cardiomyopathy. In restrictive cardiomyopathy, the walls of the ventricles become stiff, but not necessarily thickened. Introduction: restrictive cardiomyopathy refers to either an idiopathic or systemic myocardial disorder characterized by restrictive filling, normal or reduced left ventricular and right ventricular volumes, normal or nearly normal systolic functions. Restrictive cardiomyopathy is the least common of the three major functional categories of cardiomyopathy. Rare condition, ventricular filling is impaired because ventricles are stiff. Intraventricular pressure rises precipitously with small increases in volume. Lead to high atrial pressure with atrial hypertrophy, dilatation, and later atrial fibrillation. Amyloidosis is the most common cause. Other form, idiopathic perimyocyte fibrosis, familial restrictive cardiomyopathy. Pure ventricular compliance is major abnormality in restrictive cardiomyopathies, and inadequate filling of the ventricular cavities occurs during diastole and result in clinical manifestations. Restrictions: the myocardium is partially infiltrated by non-contractile tissue or extracellular material. This infiltration of the myocardium impairs the ability of the heart to dilate. Classification: myocardial, endomyocardial. Myocardial non-infiltrative cardiomyopathies, idiopathic, familial, pseudoxanthoma eosicum, scleroderma. Infiltrative, amyloidosis, sarcoidosis, and Gaucher's disease. Storage disease, hemochromatosis, Fabry's disease, glycogen storage disease. Endomyocardial obliterative. Endomyocardial fibrosis, hypereosinophilic syndrome, non-obliterative, carcinoid, malignant infiltration, iatrogenic, radiation, common for breast, lung cancer, and mediastinal lymphoma. Drugs like serotonin, methotrexate, ergotamine, mercurial agents, and busulfan. Some pictures of restrictive cardiomyopathy. Horizontal cross-section of the heart is hypertrophic and light colored and amyloid mass reserved in the ventricular wall. Histologically, light pink confirmed light pink amyloid deposit in the myocardial fibers. Sarcoidosis, epithelioid non-casseting granulomas in the conducting system of the heart. Endomyocardial fibrosis, endemic in parts of Africa, India, South and Central America, Asia. 15 to 25% of cardiac death in equatorial Africa, hypereosinophilic syndrome, thickening of basal inferior wall, endocardial deposition of thrombus, apical obliteration, mitral regurgitation, 80 to 90% die within 1 or 2 years. Pathophysiology, rigid myocardium. Here, two factors happens. One, increased diastolic ventricular pressure, so venous congestion, as a result, jugular venous distension, hepatomegaly, and ascites. Another factor, decreased ventricular filling, so decreased cardiac output, as a result, weakness and fatigue. Clinical manifestations. Symptoms of right and left heart failure, exercise intolerance, dyspnea are usually prominent. Commonly have dependent edema, ascites, and an enlarged tender, often hospitalized liver. A small sign is positive, heart sound may be distant, third and fourth sound are common. Unlike constrictive pericarditis, the apex impulse is usually easily palpable, and mitral regurgitation is more common. Thromboembolic complications are frequent in such patients. Symptoms: volume overload, fatigue, dyspnea, orthopnea, nocturnal dyspnea, arrhythmia, palpitation, syncope, exercise intolerance, reduced cardiac output, exercise intolerance, cognitive difficulties, angina, dyspnea, syncope on exertion, sudden cardiac death. Restrictive cardio findings: pulse, tachycardia, bradycardia, irregular, weak peripheral pulse. Tachycardia because of compromised ventricular filling, increased heart rate to maintain cardiac output. And bradycardia, due to sarcoidosis, involved the conducting system, so bradycardia, complete heart block may occurs. Blood pressure low, regular venous pulse, pressure raised, third heart sound and fourth heart sound audible, pulmonary crackles, inspiratory increase in venous pressure, findings of right heart failure may predominate, that is edema and hepatomegaly. Key points: hallmark, abnormal diastolic function, rigid ventricular wall with impaired ventricular fillings, bear some functional resemblance to constrictive pericarditis. Importance lies in its differentiation from operable constrictive pericarditis. Constrictive versus restrictive versus constrictive cardiomyopathy. History provides can important clues. Constrictive pericarditis, history of tuberculosis, trauma, pericarditis, collagen vascular disorders. Restrictive cardiomyopathy, history of amyloidosis and sarcoidosis, mixed mediastinal radiation, cardiac surgery. Thank you.
Thank you, Shamim, for your nice and short lecture. So this time I will invite the echocardiographic diagnosis of restrictive cardiomyopathy. This will be elaborated by Professor Tuinok. He is one of the most sophisticated in Bangladesh. I respect her regarding the echocardiographic field, and he will give us some important tips and tricks regarding the echocardiographic diagnosis of the restrictive cardiomyopathy. And you know, all sorts of cardiomyopathy is been diagnostic test is the echo. So, Professor Tuinok, madam, please start your lecture.
Okay, am I audible?
You are audible. Your slide is also audible.
Okay.
Visible. Okay, you can now go on.
Honorable moderator, respected panel of experts, distinguished audience, and dear students. Assalamu alaikum and a very good evening. I'd like to thank you, Dr. Rahiduzzaman, for his nice introduction. Today, my job is to introduce echocardiographic assessment of restrictive cardiomyopathy. I'll be very precise because it's time constraint, and for students, I will only touch the important points for echo diagnosis of restrictive cardiomyopathy. So before going to echo feature, I just want to a short recapitulation of the basic findings. That is, the primary restrictive cardiomyopathy is characterized by restricted ventricular filling due to idiopathic myocardial abnormality. That is, stiffening, fibrosis, decreased compliance, or both. There is increase in LV wall thickness is due to infiltrated disease like amyloidosis or lysosomal storage disease like Fabry's disease. Systolic function is usually normal in the early stage, but may reduce in the later stage of the disease. This entity is subset of heart failure with preserved ejection fraction. So what we get in the echo features in case of 2D, in case of restrictive cardiomyopathy. So by 2D echo, we see the ventricular size may be normal, but sometimes the low normal or reduced ventricular size, relatively preserved global systolic function. As I have already mentioned, it may vary. In the earliest stage normal, in the later stage, global systolic function may be reduced. Biatrial enlargement. I marked it red because biatrial enlargement is one of the important findings in restrictive cardiomyopathy, and it occurs as a consequence of poor ventricular compliance. There is increased wall thickness when it is due to infiltrated disease like amyloidosis. Doppler features are very important. Usually the restrictive cardiomyopathy is a global disease. It affects both the left and right ventricle. So restrictive filling pattern is present both in case of mitral inflow and the tricuspid inflow. And what are the patterns of restrictive inflow? That in case of mitral inflow, increased E velocity, that is mitral inflow is more than 1 meter per second, tricuspid more than 0.7 meter per second, decreased A velocity, mitral less than 0.5 meter per second, tricuspid less than 0.3 meter per second, increase E over A ratio in both mitral and tricuspid is more than 2, and shortened deceleration time less than 160 millisecond, and decrease in isovolumic relaxation time, which is less than 70 millisecond. When you interrogate the pulmonary and hepatic vein flow, we find that the systolic velocity is less than diastolic velocity. Increase atrial flow reversal velocity and duration in the pulmonary vein, and increase diastolic flow reversal in the hepatic vein during expiration. Tissue Doppler imaging of septal mitral annulus, there is both decrease in the systolic and early diastolic velocity. Systolic velocity less than 5 centimeter per second, and early diastolic velocity, that is E prime, is less than 7 centimeter per second. The strain imaging in restrictive cardiomyopathy, the inherent stiffness and fibrosis of restrictive cardiomyopathy is well seen in strain imaging with reduced global longitudinal strain in the basal segment, which progresses to the mid and apical segment. Here is an example of all the parameters. On the upper left, in the 2D apical four-chamber view, we can see that there are low normal ventricular size, relatively reduced LV and RV size, but there is biatrial enlargement. LA and RA are dramatically enlarged. And mitral inflow, it shows the restrictive pattern, tall E wave, short air wave, EA ratio is more than 2, and the deceleration time is shortened. Tissue Doppler imaging of the mitral annulus, that's the medial side, it shows reduction in both in the systolic motion, that is annular systolic velocity, and the annular diastolic velocity. Pulmonary vein Doppler interrogation, it shows that there is reduced systolic velocity and increase the diastolic velocity. Hepatic vein Doppler, it shows the inspiratory reversal. In case of constrictive pericarditis, there is expiratory reversal, but in case of restrictive cardiomyopathy, there is inspiratory reversal. And strain imaging, it shows the basal part, the mostly reduced the strain, then the mid part and apical, but comparatively, there is less reduction in the strain pattern. As Dr. Shamim already mentioned that amyloid cardiomyopathy typically presents as restrictive cardiomyopathy. I want to give an example that in case of amyloid cardiomyopathy, the important echo feature is diastolic dysfunction, which is common, earliest, and the most important feature. There is symmetric alveolar wall thickening, typically involving the interventricular septum, a granular speckle appearance of the myocardium, small ventricular chambers, and dilated atria. Thickening of the atrial septum, increased RV wall thickness with RV diastolic dysfunction. Here is parasternal longitudinal view showing that both the septum and the infralateral wall are thickened, and there is ground glass appearance, the speckle granular appearance, and there is little pericardial effusion. Pericardial effusion may present 1/3 of cases of amyloid cardiomyopathy. Here, 2D echo feature on the left, parasternal longitudinal view. Here, the middle, the short axis view showing that the septal hypertrophy the most, and also the other wall are hypertrophy. Apical fourth chamber and the subcostal view. Both view shows that there is biaxial enlargement. And here the tissue Doppler view showing reduction in the systolic as well as the diastolic. So systolic annular velocity and the diastolic annular velocity both are reduced. We can see only there is the diastolic annular velocity 0.4 centimeter per second. And the strain imaging, it shows there is reduction most in the basal part, then the mid part, and the apical part is relatively preserved. This is the characteristic strain finding of amyloid cardiomyopathy, that is the apical sparing. It is also known as a cherry on top pattern. That is, the strain is reduced in the basal and the mid part, but the apical part relatively preserved strain. As there is always, like in the not always, but most popular is to differentiate between the constrictive pericarditis and from restrictive cardiomyopathy. I want to emphasize the echo feature, how we can differentiate. That the most important is the atrial size. That in case of restrictive cardiomyopathy, the atrial size is dilated. Pericardial appearance is thick and bright in case of constriction, but is normal in case of restrictive cardiomyopathy. Septal motion, that is in case of constrictive pericarditis, one of the important findings is the abnormal septal motion, that is the septal bounce, but septal motion is normal in case of restrictive cardiomyopathy. Septal position, there is left shift with inspiration in case of constrictive pericarditis, but is normal in case of restrictive cardiomyopathy. Mitral EA both may present with restrictive pattern, so ratio is more than 2. Deceleration time short in both cases. Lateral velocity is maybe normal, but reduced in case of constrictive, in case of restrictive cardiomyopathy. I have already mentioned that it is a global disease, and if it affects the medial and lateral annular velocity equally, and there is reduction in the annular velocity. But constriction, what happened in constriction? The constriction from the lateral side. So lateral annular velocity decreased, but the medial annular velocity increased. So in case of constrictive pericarditis, there is increase in the medial annular velocity and decrease in the lateral annular velocity. But in case of restrictive, medial annular velocity is more than the lateral annular velocity. Medial annular velocity is less than the lateral annular velocity. This is more important. So I want to repeat again that in case of the constriction, medial annular velocity is more than the lateral. But in case of the restriction, medial annular velocity is less than lateral. And pulmonary hypertension rare in case of constriction, but it is frequent in case of restrictive cardiomyopathy. LV size and function normal in both cases. Mitral tricuspid regurgitation infrequent in constriction, but more frequent in case of restriction. Isovolemic relaxation time, I've already said that there is stable, and it varies with respiration in case of constrictive pericarditis. Respiratory variation of mitral valve E velocity. During my lecture on constrictive pericarditis, I have mentioned that it is very important. And in case of constrictive pericarditis, there is exaggerated respiratory variation in the mitral E velocity. And when it is more than 25%, it is a very sensitive pattern for diagnosing constrictive pericarditis. But there is no or relatively low respiratory variation. So respiratory variation is usually absent in case of restrictive cardiomyopathy, and there is exaggerated respiratory variation in the mitral E velocity in case of constrictive pericarditis. When we do color in mitral valve propagation velocity, it is increased in constrictive pericarditis, but reduced in case of restrictive cardiomyopathy. So these are the important echocardiographic points to differentiate between the constrictive pericarditis and the restrictive cardiomyopathy. So here, the most important, the Doppler pattern, the conventional Doppler mitral inflow. In case of restrictive cardiomyopathy, we see that there is restrictive pattern, that is the tall A, short A, and short DT, but there is no respiratory variation. But in case of constrictive pericarditis, we can see there is exaggerated respiratory variation. Sometimes it is very tall and sometimes it is short. So this mitral E wave velocity, there is more than 25% variation in case of constrictive pericarditis. And the annular velocity, we can see the both systolic and diastolic, there is marked reduction in the annular velocity. But in case of the constrictive pericarditis, when the constriction from the lateral side, there the mitral tricuspid lateral side, that the annular velocity is relatively less affected. But restrictive cardiomyopathy, annular velocity is reduced. And here, with the help of advanced imaging modality, that is strain imaging, we can see that as restrictive cardiomyopathy is global, there is reduction in global longitudinal strain, both septum and the lateral wall. But in case of constrictive pericarditis, the septal strain is preserved because the constriction from the lateral side. So it may be normal or reduced in the lateral wall strain, but the septal strain is usually preserved in case of constrictive pericarditis. And apical rotation is reduced in case of constrictive pericarditis, but it is not affected in restrictive cardiomyopathy. The longitudinal strain in RV, it may be reduced in both cases. And in case of left atrial strain, that is the actual septal reservoir strain, it is increased in case of constrictive pericarditis because the constriction is from the outside. But in case of the restrictive cardiomyopathy, as it is global, so actual septal strain is reduced. So with advanced imaging modality like strain imaging and with normal conventional Doppler and tissue Doppler imaging, we can differentiate these two different entities, that is the constrictive pericarditis and the restrictive pericarditis. So with this, I'd like to thank you all. Okay, and I'd like to request Dr. Qayyum for his presentation.
Thank you, madam, for your short, elaborate, and informative lecture. Very nice to pick up. Now, Dr. Abdul Qayyum Khan, he will talk about the diagnosis and treatment of restrictive cardiomyopathy. Dr. Abdul Qayyum. Time is short, life is long.
So lecture is long, discussion will be short. 1.5 hours past.
So be precise, Abdul Qayyum.
Thank you, sir.
Okay, go on.
Am I audible, sir?
Yes, you are audible and visible both.
Am I audible, sir?
Yes, audible.
Yes, you can start now. Abdul Qayyum, you can start. We can see you.
I think there is some net problem.
Kohir bhai,
Huh?
already 9:45.
Okay. Again, share your screen.
Can you see my screen, sir?
Yes, I can see your slide. Please go to the slide show.
mode.
Am I audible? Am I audible, sir?
Yes, or you are audible. You can go on. Yes.
Thank you, sir.
Okay.
My topic is diagnosis and management. So, respected moderators, panelists, and audience, Assalamu alaikum. Inshallah, I will try to be short. So, in diagnosis, the accurate diagnosis of respiratory cardiomyopathy is difficult due to similar clinical and hemodynamic presentation of constrictive pericarditis. But it is the utmost important for treatment and prognosis. A full cardiac evaluation with clinical and other multimodal approach, including radiography, echocardiography, computer tomography scanning, magnetic resonance imaging, and invasive angiography is necessary. My previous speaker already discussed about the clinical feature, so I will focus only the laboratory investigation. So in laboratory investigation, we can send a complete blood count for and peripheral smear to establish eosinophilia, blood gas analysis for monitor hypoxia, serum electrolyte, blood urea, serum creatine level, liver function test, and serum iron profile to evaluate the hemochromatosis, serum BNP, as data suggested that serum BNP level are nearly normal in patients with constrictive physiology of heart failure, but grossly elevated in restrictive physiology of heart failure. In case ECG, it may be normal or low voltage ECG or low voltage QRS complex, or may be found large POF indicating biatrial enlargement, maybe conduction delay, high grade AV block, or various STT changes, and tachyarrhythmia, especially sarcoidosis, atrial tachyarrhythmia, including atrial fibrillation. With the sample ECG, you can find the STT changes and fast degree heart block. In chest radiography, it may show usually normal cardiac with manifestation of pulmonary venous hypertension and pulmonary congestion. There may be other sign of congestive heart failure, but there's no pericardial calcification, which is the signs of constrictive pericarditis. Echocardiography already described our Professor Madam. In cardiac catheterization, it reveals elevated diastolic pressure. Left ventricular pressure is higher than the right. There's a square root sign, deep and plateau. In diastole, rapid early diastolic feeling deep, followed by plateau during pressure tracing, which is seen in both restrictive cardiomyopathy and constrictive pericarditis. In restrictive cardiomyopathy, the variance between the right and left ventricular diastolic pressure is more likely to be greater than 5 millimeter mercury. But in constrictive pericarditis, left and right ventricular feeding pressure, the difference is not more than 5 millimeter mercury. In RV-EDP, is more likely to be less than 1/3 of right ventricular systolic pressure. But in constrictive pericarditis, right ventricular end diastolic pressure equal or exceed more than 1/3 of the right ventricular systolic pressure. RV systolic pressure is more likely to be greater than 50 millimeter mercury, but in case of constrictive pericarditis, it's less than 50 millimeter mercury. We can also do cardiac MRI, which is a with high diagnostic accuracy for constrictive pericarditis, which can be present similar to the restrictive cardiomyopathy. It is important to distinguish from restrictive cardiomyopathy from constrictive pericarditis, as the different surgical therapy available for constrictive pericarditis. It's a gold standard for non-invasive diagnosis of cardiac hemochromatosis. We can also do the cardiac computed topographic scanning. Its diagnostic role is very limited, despite the disadvantage with regard renal insufficiency or radiation exposure. CT scan may be an alternative module if CMRI is contraindicated or unavailable. CT scan also be used to investigate coronary artery disease in selected patients where angular chest pain is present. So we can also perform biopsy. Biopsy is confirmatory. There is a lot of indication, but here we can use in acute cardiomyopathy with refractory heart failure symptom, rapidly progressive ventricular dysfunction in unexplained cardiomyopathy, neonset cardiomyopathy with recurrent ventricular tachycardia. And principal purpose of right ventricular endomyocardial biopsy has been differentiated between the myocarditis and from infiltrative cardiomyopathy. So treatment, respiratory cardiomyopathy has no specific treatment and cannot be cured. However, therapy directed at the individual cause of respiratory cardiomyopathy has been shown to be effective. Treatment aims to reduce the control the symptom, particularly those of heart failure. And treatment goal including systemic and pulmonary venous congestion and lowering the ventricular feeding pressure, augmentation of the systolic pump, and reducing the risk of embolism. We can use beta blocker, calcium channel blocker, diuretics, SC inhibitor, anticoagulants, and vasodilator. Beta blocker and calcium channel blocker improve symptom by increasing left ventricular feeding pressure and improving the ventricular relaxation time. So beta blocker also decrease the compensatory sympathetic stimulation. Diuretics may reduce the pulmonary and systemic congestion, which may improve symptom by venous congestion, high inhibition of return fluid, and pleural reduction. But initial therapy start with a low dose because the high level of ventricular filling pressure must be maintained for adequate diastolic filling. ACE inhibitor reduce the water of the heart. Antiarrhythmia, usually we can give amiodarone and beta blocker for antiarrhythmic drugs. Anticoagulation needed for prevent stroke. We can all use other medication such as melphalan, chemotherapy, corticosteroid, cytotoxic agents, and chelation therapy. Other treatment options like pacemaker. Patient with idiopathic distributed cardiomyopathy may have fibrosis of SC node and AV node that may result complete heart block, therefore require permanent pacing. Patient with amyloidosis may present with sinus node dysfunction or advanced conduction system disease, also require treatment with implantation of a pacemaker. Another option is endomyocardiectomy. In the fibrotic stage of local endocarditis, surgical therapy with excision of fibrotic endocardium and replacement of the mitral and tricuspid valve is palliative but may provide symptomatic improvement. But mortality is very high, 15 to 25%. We can use left ventricular assist device, can be considered in highly selected patients with refractory symptom who have idiopathic familial restricted cardiomyopathy. Can be used in elevated pulmonary vascular resistance, which exclude patients from cardiac transplantation. It also may require as a bridging to transplantation. And final option is the cardiac transplantation. Cardiac transplantation is widely accepted treatment for improve the long-term survival of the patient with advanced restrictive cardiomyopathy. Unfortunately, patient face long waiting period. Many patients irreversible pulmonary hypertension and die from heart failure complication before they can receive a donor heart. When a non-cardiac organ involvement is absent, a few patients with amyloidosis have undergone successful cardiac transplantation in combination with post-operative high-dose chemotherapy. Combined heart and liver transplantation in patients with heart and liver failure due to hemochromatosis has been successful in small number of patients. However, early mortality and mortality are high in dual organ transplantation than a single organ transplantation. Other novel therapy, advancement in chemotherapy regimen and the use of autologous hematopoietic cell in transplantation in some patients have shown to improvement. So, my keynote take-home message: in restricted cardiomyopathy, endocardial thickening, myocardial inflammation lead to rigid, non-compact ventricle, has diastolic dysfunction. Systolic function is normal until the late stage. Sometimes valvular tissue or conduct tissue is involved, causing valvular regurgitation or heart block arrhythmia. Etiology usually unknown, but some cases cause may be amyloidosis, hemochromatosis, or sarcoidosis. Diagnosis is by echocardiography or other investigations for causes. Treatment is often unsuspected unless the cause can be addressed. Diuretics may be benefit patient with edema or pulmonary vascular congestion, but must be used cautiously to avoid lowering the preload. Standard treatment for dilated cardiomyopathy such as ACE inhibitor, dioxin, beta blockers are poorly tolerated. Cardiac transplantation is widely accepted treatment to improve long-term survival. Thank you. Thank you all.
Thank you, Abdul Qayyum, for your lecture. Now so thank you. Now, dear panelists and audience, and now I will take some of the questions from the students. There are 4 questions in the chat box. Then I will go to the expert panelists and then to others. Munawar, are you with us?
Yes, sir.
Thank you. I will talk there are a few questions. One is what is the role of the strain echo in diagnosis of HCM? I think that can be answered by Dr. Abdul Majid Khan. Dr. Abdul Majid Khan, can you talk about what is the role of the strain in diagnosis of the HCM?
Yes. Can you hear me, please?
Yes. In short.
Strain echo plays a very important role, as I've shown in my slides that despite preserved rejection fraction, the strain pattern shows the heterogeneity in different segments of the left ventricle, and I've shown that the global longitudinal strain is a decrease in asymmetrical septal hypertrophy, and if there is left ventricular basal to apical gradient.
Okay.
Usually in asymmetric septal hypertrophy, it is decreased more in the septal and interseptal region, and the apical variety, it is more decreased in the apical segment. And
Okay,
I've
sir.
shown that, and
Then,
I've
sir,
shown that,
what I want to add with you that actually hypertrophic cardiomyopathy is the anatomical diagnosis that can be definitely done by the 2D echocardiography. Strain have the part to role the play the LV systolic function. It is no role in the diagnosis. It can play the role in the diagnosis of the LV systolic dysfunction. But 2D echo is the gold standard echocardiographically to diagnose the hypertrophic cardiomyopathy. Okay, then another
question was
what
role
is the role of the
strain.
what is the strain diagnosis of the HCM?
I didn't describe for the diagnosis of
Yes.
HCM.
Yes. Actually, okay, sir. Then we will to talk anything another. Sir, what will happen if a patient of HOCM have an anterior septal MI, anteroseptal MI? I think that can be answered by the Dr. Habibur Rahman. Dr. Habib, can you hear me?
Yes, sir.
Then anteroseptal MI, what will happen to the HOCM?
If MI occurs in anteroseptal MI, it not only involves the septum, also involves the other part as well. So there will be some reduction of the gradient. It will improve, but it's not definitive because septal, what we do by percutaneous or by surgery, it is specific location for specific location and programmed infarction. It's not that much effective. Its efficacy will be unpredictable. So there will be some reduction of gradient.
Okay, thank you, sir. There will be some
may
septal
I
thinning.
Koirbai, may I add something regarding?
Okay, you can add, but precisely.
Yes, definitely that is important. Anteroseptal MI, that if it happens by occlusion of the LAD proximal to the first septal, that will produce usually reduction of the LV-OT gradient. I have one experience. One of our senior professors, his wife is my patient with HOCM.
Yes,
she admitted with non-STEMI, and after 2 months, we did the echo. Her gradient was normalized. That means LV septum was almost was hypertrophic, but gradient was normalized. So that was good for her. That LVOT gradient reduces, but without massive damage of the IVS. So that is one of the example that anteroseptal MI, if it is not massive, that may be helpful sometimes.
Yes, that's an actually it depends upon the clinical scenario or outcome of the MI. It may vary with the person to person, patient to patient. Then another question is how well can measure the LVOT gradient in Doppler study and differ from HCM? I think it has been elaborately discussed in the echocardiographic feature portion of the hypertrophic cardiomyopathy. Then we can go to other year. So I will now request to the panel of experts, Dr. Tanzima Parveen, to speak few words regarding the examination perspective to our students. Dr. Tanzima Parveen.
Thank you, Sir Rahiduzzaman, sir, for asking me to say something. I would like to highlight for students 2 or 3 points. All speakers elaborately discussed restrictive cardiomyopathy and also hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, although is a rare disease, but commonly asked topics in exam, in written exam, also in long case and short case and viva board. In in written question, common question, how will you evaluate a patient with exertional dyspnea? It is a common question, frequently given in a written exam. And in long case, hypertrophic cardiomyopathy comes as a discussion as a differential diagnosis of aortic, commonly given long case aortic stenosis and aortic regurgitation, or simply aortic stenosis. And their students are commonly asked during pulse examination, what is pulses bispherians, and differentiation of pulses bispherians from pulses bigemini or pulses alternans. And students should also examine in long case in precordial findings dynamic auscultation and how they differentiate hypertrophic cardiomyopathy and given long case aortic stenosis and aortic regurgitation. So this part described clearly by Dr. Ishrat, and I asked, I congratulate all the speakers. And another question commonly given in OSPE exam, especially ECG, and another part is echocardiographic part. ECG is commonly given LVS with stent pattern or giant T-wave inversion, which is commonly found in hypertrophic cardiomyopathy. And they are precordial. With this ECG findings, commonly asked question, the precordial findings of this group of patients. And this is a common question in OSPE exam.
Yes, yes.
And in echocardiography, and there is a common question, the 2D and M mode findings of hypertrophic cardiomyopathy.
Yes,
and
yes.
differentiation, this, and differentiation from athlete's heart or hypertensive heart and hypertrophic cardiomyopathy. So these are some exam related questions, and I given thanks to all speakers and my teachers. Assalamu alaikum. Thank you.
Thank you, Tanzima, for your very brief and informative exam related information. Now I will request Dr. Monwarul Islam, is the expert panelist. Please talk about our events, discussion, and few words regarding issue addressing the students. Dr. Monwarul.
Thank you, sir. Thank you, sir. Thank you all for inviting me. Actually, I am happy because these two entities, especially hypertrophic cardiomyopathy and even more important for restrictive cardiomyopathy, these entities are in the gray zones of cardiology. And they are discussed, but they are incompletely dealt with in our day-to-day life, especially restrictive cardiomyopathy. And I must realize that we often do not complete or cannot complete the full workup of restrictive cardiomyopathy in Bangladesh. And we should think of doing something better in future. And often we are not so eager to deal with this entity. Some practical tips I must tell you that, especially for the fellows, that restrictive cardiomyopathy cases are not included in the long or short cases in the exam, in FCPS cardiology and also MD cardiology, diploma cardiology. These are not given. Hypertrophic cardiomyopathy are usually not given. If some cases are included, they are usually included as long case. And if this is included and you are fortunate or unfortunate enough to have the case, please don't be biased. It may be safer to make the diagnosis as the aortic stenosis in a long case exam. One of our renowned cardiologists is now a professor of cardiology, just failed in his MD in the first attempt because he made the diagnosis of hypertrophic cardiomyopathy in the long case. The examiner may have ready-made impression that you know the case.
Yes.
So if you are unfortunate or fortunate enough, please try to make the diagnosis aortic stenosis in the long case. And then during discussion, you can ultimately make the diagnosis of hypertrophic cardiomyopathy. In my long case, I had actually a case of PPH. And I knew, the case was known to me. And Shirajul Haq sir was trying to harvest the exact diagnosis from me, and I did not walk along the path. And I always wanted to make the diagnosis of pulmonary hypertension due to this. And whenever after 5 or 10 minutes passed, then I uttered the term PPH. So be cautious regarding the diagnosis. And there are some classical things that are usually expected during hypertrophic cardiomyopathy. One is regarding pulse, and though the bookish term is spike and dome pulse, but more expected terminology is a jerky pulse. And this jerky pulse is usually felt over the carotid. So the fellows should tell the classical pulse of hypertrophic obstructive cardiomyopathy is the jerky pulse, number one. Number two, the classical description of the apex speed of hypertrophic obstructive cardiomyopathy is double apical impulse. You should also think of this. Number two, and Tanzima Appa has already described that they are more discussed as the theoretical entity in the OSPI, in the VIVA, especially as the echo, sometimes ECG, and even in the VIVA table as the list of entities like hypertrophic cardiomyopathy, rheumatic heart disease, this. They are often theoretically discussed. I have heard some examiner once upon a time, he asked the examinee that what are the classical features in ECG of hypertrophic cardiomyopathy. Actually, no classical features. The usual presentation is just left ventricular hypertrophy, but he expected the special feature that there may be Q waves in the lateral leads and sometimes the inferior leads. And these Q waves differ from the classical Q waves of old myocardial infarction, that they are usually slender and deep. So you can just memorize this. These two or three things regarding hypertrophic cardiomyopathy. And regarding restrictive cardiomyopathy, just one or two practical points that can be helpful in your practical life, that whenever you are doing echocardiography, just pay special attention to biatrial enlargement, as Madam has already told. This is a very good clue for the proceeding for the diagnosis of restrictive cardiomyopathy. And another dictum I like to utter, and that is that whenever you are doing echocardiography and getting a hypertrophied heart, and the ECG is of low voltage, always think of cardiac amyloidosis. In echo, hypertrophied heart, and ECG, low voltage ECG. The diagnosis is virtually confirmed that you are dealing with cardiac amyloidosis. Because in Bangladesh, full workup of cardiac amyloidosis is right now not possible. So you have to think of some practical tips. With this, I like to express my thanks again for the authority of Heart Foundation, and hope to be with you in future. Thank you all. Assalamu alaikum.
Thank you, Manohar, for talking so many important tips to our students. Now I will request Professor Nazir sir to talk about few words regarding our fellows.
Koir bhai, can I ask one question, please, to Manor
Say,
or
yes.
the panelists? Is
Yes,
there any
yes.
specific MRI findings for restrictive cardiomyopathy?
No specific finding, because restrictive cardiomyopathy is actually a heterogeneous entity, and
Yes.
it includes from idiopathic variety to sarcoidosis, hemochromatosis. So the patterns are not specific.
Okay.
When you have to investigate other etiology.
Yes.
Yeah. You have to investigate other etiological factor. If you don't
Right.
get any reason, then it is idiopathic or primary HCM.
And with
Things
this
actually we are
opportunity, I like to request Heart Foundation to have some scope for endomyocardial biopsy.
Yeah.
Right. Thank you, sir. Thank you all.
Okay, thank you.
Thank you.
Then Professor Nazir sir. Sir is not. Okay,
Hi, sir.
Professor
Hi.
Rahiduzzaman sir. Professor Rahiduzzaman sir. Will you talk something about this?
No, thank you. Thank you. Dr. Rahiduzzaman. Actually, nothing more to add. There was so much elaborate discussion of all the topics. And I think nothing. The only thing I want to share with Dr. Habibur Rahman, it's very difficult to treat a patient with HCM and angina. No drug is actually effective in treating angina in a patient of hypertrophic cardiomyopathy, because the pathophysiology of angina in cardiomyopathy is different. So just a question to Dr. Habibur Rahman. When you will decide to ask the patient for an angiogram in a patient with HCM, maybe with a gradient of more than 50 or 60, having typical history of angina, will you, when you will decide that patient should undergo an angiogram, diagnostic coronary angiogram? Dr. Habib.
Thank you, sir. When maximizing the drugs, symptoms of angina or respiratory distress is not controlled, so it needs evaluation of coronary artery disease coexistent. If coexistent coronary artery disease, it should be treated. That's why angiogram should be advised. Another point is by angiogram, we can identify the artery which can be blocked for controlled MI for reduction of gradient.
Okay, just supplemental question to you. As you have shown, what is the how you compare between alcoholism and alcohol ablation and coil ablation? Which one you prefer is better in treating hypertrophic cardiomyopathy? Is it
as an interventional cardiologist? I should prefer alcohol ablation.
I think coil ablation is more because alcohol ablation, there is every chance of recanalization. There is a very high chance of recanalization in alcohol ablation, but in coil ablation, I think if you do a coiling, then
sir,
it
can
is.
Can I add something?
I would like to add another point. In coil ablation, there is recruitment of collaterals, so there is recurrence may occur. In the
can I add
alcohol
something?
ablation, yes.
Hi, bhai, can I add something? In case of coil embolization, there is a risk of complication is less than alcohol ablation. In case of alcohol ablation, there is a chance of complete heart block is more than coil embolization, and it has been seen in different articles. So
may I add something, Guruji, sir? Just regarding this is actually in coil ablation, there is total occlusion of the septal artery, but subsequently the collateralization from the other vessels happens. So efficacy is less. In alcohol ablation, not only the MI, controlled MI, actually that alcohol degenerate or coagulate the whole muscle. So that is the indirect way, not only the MI, that degenerate the muscle. So initially, if on table, if we see the echo, there is coagulation like mass in the proximal septum. So this both way, one is ischemia, another is the coagulation necrosis of the muscle. So this is more complete.
Scar is an important factor for efficacy.
Thank you. Thank you.
But complication is more, Habib bhai, in case of
yes, definitely complication is more.
Okay.
But there should be efficacy.
Okay.
And you should put a pacemaker also, yeah.
Then is there anybody to want to say some few words regarding these issues?
Can I add something about alcohol ablation and coil? So for the students who are aware, just a brief recap as well. In our hospital, regularly hypertrophic obstructive cardiomyopathy is being treated both surgically as well as by coronary intervention. And in case of surgery, Major retired Kamrul is the one who does most of the surgical myomectomy. In case of intervention, most of us have dabbled in doing ablations, but I must say that Dr. Ashok Datta is the one who's most passionate about doing alcohol ablation. I personally have done both alcohol as well as coil embolization. And my personal experience, very limited. It's not as huge as Ashok's, but my limited experience, I think alcohol is more effective. I mean, you get the job done. With call, you see then the collateral starts recruiting, and then you really don't get that great a job of,
Yes,
like with echo findings, you get it better results with alcohol. I mean, I have a very limited experience, but that's what I personally felt. So that's my
Madam, very
experience.
Actually, I want to add my experience. One experience is that in our hospital, one patient was gone for the septal myectomy, surgical. But after still there was LVT grade. And they think that there is additionally mitral valve disease, and they replace the mitral valve. So in our today's abnormalities of the mitral valve apparatus, including the length of the ML is
even even in septal myomectomy, we have seen several cases, and we have to put permanent pacemaker also. There's another complication for myomectomy.
Well, actually, a pacemaker you might end up even with
so.
alcohol.
So they have done the replacement of the mitral valve. Now, is there anybody to talk about this? Yes. Yes, madam.
No, about mitral valve, Ashok has experience with where his mitral valve, actually mitral regurgitation, improved substantially after alcohol.
Yeah, definitively. MR, ma'am, MR, most of the MR DJ peers, if alcohol ablation is successful, most of the MR DJ peers.
Actually, there are some varieties of the hypertrophic cardiomyopathy. Those who have the long anteromitral leaflet and have the anomalous insertion of the chordae. Their apical part of the mitral leaflet acts like a flap. That varieties are very uncommon, but sometimes they come into play. Those are the cases, usually they do not respond with the alcohol ablation or septal myectomy. These are very tricky patients. Is there anybody want to speak?
If you compare between surgery and invasive, though there is selection of patients, those who are not fit for invasive management, but I think still the study shows that surgical myomectomy is far superior than alcohol ablation, or it is far superior. Myomectomy is the treatment of choice, unless the patient is unfit for treatment. Otherwise, all the patients should be sent for myomectomy unless the patient is unfit for surgery. That's the bottom line.
At the end, one thing is important, provided that center or particular person is specialized.
Exactly. Yes, it should be. That's right. The operator must be expert in doing so. Not all the surgeons. Yeah, in our center we have got an expert, as Professor Fawzira Malik has said. He is doing a lot of cases, so I think we can send the patient to him because he's already very expert in doing.
Just one point. I mean, we know that we have a surgical expert as well as expert in intervention. But personally, my feeling is that just for surgical myomectomy, do we want to open up someone's chest? Because maybe in the future he might require CABG or something. And once opening the chest and again reopening for a CABG. So, I mean, for this patient maybe, or for some other reason, he might require surgery in the future. So, wouldn't it
I don't think that can be an indication for not doing surgery, because when a patient is
but just realistically speaking.
Now, when the data suggests that surgery is the definite treatment, and if we have got an expert who is doing myomectomy very good, and patient with very high gradient, very thick myocardium, as you have shown in a very thick myocardium,
life expectancy is more.
So there's, I think surgery should be done. Surgery is the answer only, and well, it is that the patient might.
Recent the number of surgery, number of ablation is much higher than the surgery, and the total result. If you go through the recent papers,
I've just today I have gone through the recent papers, so I'm telling you that even the latest results show that surgery is far superior than ablation.
What do the guidelines tell us? I mean, for our students' examination purpose, what is the guidelines basically for invasive
guidelines? Guideline, as Dr. Habib has shown, that patients who are not fit for surgery, old age, comorbidities, that patient should undergo ablation. Otherwise, younger patient, fit patient should all be advised for. As I think Dr. Habib has shown that chart of ACC guideline.
And is this surgery a class 1 indication, or is it a 2A or 2B indication, Dr. Habib?
Class 1 indication.
Surgery is class 1.
Class 1.
What about ablation?
Major studies
both class 1.
Both class 1.
Madam, yes. I have a question, madam. Yeah, what are the anti-anginal drug we can use for hypertrophic cardiomyopathy with low blood pressure?
That is very difficult.
Ask the presenters. I don't know.
Even patient having a high LVOT gradient.
For MD student, that is important. One thing, few things that you should know regarding angina. First, nitrate should not be used here.
Yes.
Other anti-anginal, including the rate limiting drugs, and newer drugs sometimes may add. Recently, on a study that shows mavacamten, that is a newer drug. That is the name you should remember in exam. Some may be asked. There is a study, Explore study, that reduces the LVOT gradient, that acts on the actin myosin. Actually, that is a new drug, but already on a study completed in last EuroPCR, that is shown that have a good drug that reduces the angina, that reduces the LVOT gradient. That is the mavacamten.
Ashok, is there any role of what's the role of trimetazine or ranolazine in?
That is effective. Sometimes that is effective, definitively, but not the nitrate. Even nicorandil also effective. Sir.
What about disoparamide in patients with low blood pressure?
That also.
Disoparamide also is a drug for
Actually, literature says disoparamide should be prescribed for the resting gradient. If there is resting gradient of hypertrophic cardiomyopathy, disoparamide is the first drug of choice. If there is dynamic obstruction, that LVOT obstruction appears after some maneuver, then is the beta blocker is the first drug of choice.
Yeah, sometimes we have seen the patient having hypertension with high LVOT gradient, and some physicians using a vasodilator, especially ACE inhibitor by ARB. Is it indicated for this situation?
Should be avoided. Should be avoided.
Yeah.
Regarding apical HCM, twin madam, and I have got some experience. Several patients I sent to twin madam, HCM, someone did the angiogram, first CT angio, then conventional angio, several patients with this ECG change. And ultimately that patient, after 2, 3, 4 years, diagnosed as apical HCM.
It's more difficult to treat apical HCM. No surgical option.
Actually,
no
yes, apical HCM, the clinician should guide the echocardiographies that you are suspecting the apical HCM. Things is like that.
Sir, what is the role of CT angio in case of HCM other than conventional angiogram?
CT angio have no role. have no role, you can do the contrast echo, have the recommendation, but another thing is that, but actually the ecography is a width to make the high resolution. Then many of the times it may be diagnosed. Actually, the ECG and the
MR angiogram has definite role for diagnostics apical.
Right. But CT have no role.
Yes.
CT doesn't have role. Besides echo, MRI imaging. So CT is not
regarding concomitant coronary artery disease, to exclude concomitant coronary artery disease.
That's for screening of coronary artery disease.
What is the role of CT angio other than conventional angiogram?
That is for screening. The screening of coronary artery disease, not for diagnosis of HCM.
No, not for diagnosis.
Yes, and for diagnosis of apical HCM, one should be very precise. So to look for the apex, and contrast echo helps. Contrast echo very much helps in diagnosis of apical HCM.
So we are at the end of discussion, madam. Will you speak few words addressing our fellows? Then we want to conclude our session.
Well, thank you. This was a great learning experience, and I'm so grateful to our panel of experts who gave greater insight, and we learned such a lot. At least I personally always learn such a lot from these discussions. So thank you, everyone. All the speakers were wonderful. Thank you so much.
So with all this, we want to conclude the session. Thank you for participation. I must thank Dr. Manohar and Tanzima for participating our session. I must congratulate and thanks all the speakers for speaks very smartly and elaborately. So thank you all. Wish you all very good and happy and safe life. Stay safe, be blessed.
Thank you.
Thank you.
Thank you.
Assalamu alaikum.